Gary?
Ready, go.
All to work. Whoever's taking minutes can take the minutes. Good deal. I hope you were. Julie, we'll turn it over to you.
Okay, so, I guess we all know each other when, do you know Jeff Beck?
No, I don't.
So when he gets here, we'll,
Yeah.
okay. Does the agenda look okay to everyone?
You actually have your full board packets for today, so each committee is in
Oh,
there
you have to
also.
I'm sorry, we
you
have
have
to
to
go-
find our particular.
You should be the very last pack
I'm
in your
actually-
packet.
We are actually,
There we go.
the Performance and Quality Committee, I got a little reversed. Kept the same words in there, so, but,
Motion to approve the agenda? So moved.
Kat, do you?
So moved. You second?
I'll
that?
second.
All in favor, say aye. Aye. All opposed? Motion carried. Approved, agenda approved. If that's what you were looking for,
Yes, absolutely. I guess we do the same with the minutes, they look very concise.
Okay.
Where are
they're right after the agenda? First sheet after the, I mean, you said they're concise, they really are.
they? Alrighty,
Well, we have them.
that's good, you have them, that's what's
Take a
important.
look, take a moment to look at
You're
the
looking at your
minutes.
stuff, not the board packet.
Okay.
That's why you don't have your
Okay.
calendars.
Never, I was unable to attend, just so you know, I had death in the family, I was gone for about 2 weeks, so I do this. Have we had enough time to look at minutes?
Yeah, I believe I asked a question about whether we had any clients taking advantage of this, but I guess it's okay that it's not in there.
Pat, part of the reason it's not in there is that we do not detail, in the minutes, we don't detail the
Okay.
complete discussion, just the topics.
Primarily action items,
Okay.
but we acted on your item.
You did, I appreciate that.
Is there a motion to approve the minutes?
I'll make a
motion.
Okay, and a second? Okay, motion and a second, all in favor say aye. Aye. All opposed, nay. Minutes are approved. Okay.
And you have a notebook for him that's back at the office too, right?
No, don't just
Oh, you mailed it to him, okay.
Yeah, I have a notebook.
So, all right, so that was basically an orientation of all the reports. So what I have created for you guys is a recommendation about a schedule for us. We are required, if you'll look at, we are required to review, if you'll look at May, these 3 items quarterly. The grievance report.
We're gonna catch everybody up. There you go.
Okay, thank you, Carl.
No problem.
The grievance report, the incident report, and the access to care report, we're required to, you, as a board, are required to review that quarterly. This committee is reviewing that on the board's behalf. There are other items stuck in here that the board is required to review annually, such as next month we'll be looking at the QM annual report. And then at the
Will you
bottom.
be able to email these or provide us copies before the meeting?
They were,
So that
they
we
were
don't have to
sent
go over
last
them?
week.
Right, I'm just saying that generally, we
I will
don't
always
have
do
to,
that.
and we don't have to go through them in the meeting, except to the extent that you need to brief us on
Correct.
highlighted issues,
Correct,
but we won't spend a lot of time just reviewing
Correct.
their report. Cool,
correct.
thank you.
It is my hope that the committee will review them and bring questions.
Good.
That's, I think, one of the reasons that we can keep the meeting to an hour. But these top reports up here, the monthly ones, we'll go through the highlights monthly.
I don't know about
As
the
is
other
necessary.
committee members, I know we're supposed to be in a paperless world with email. I find it really hard to read these reports unless they're in hard copy. Would you all like to have them, or can we request that they be provided to us in hard copy?
You do have them.
No, today.
I'm
I'm
gonna
just
do-
saying,
I-
rather than just email it to us, would you also stick them in the mail that day? How would you feel
Oh,
about
mail
that?
them ahead of time.
Because I'm finding them very difficult to look at. I mean, I started glancing at them online.
That's
It's
up to
like
you because-
my eyeball went like this.
I spent 2 hours this morning looking at them.
So you want this committee packet mailed to you separately from
the board packet.
Well,
Just-
see-
When you email it to us, mail it to us.
I miss getting a board packet in the mail. I really miss that, cause I like to sit down and write notes on it. You know, and we did that before we had this new structure, and now we're not getting
I
a
know that part of that is,
finance
our general counsel's,
suggestion.
yeah, but, please ask for one in paper, and,
Well,
I mean, if that's what you would like, then I think that
I mean, it would be my preference. I know, Lord, I've got enough baskets of papers now at home, but it'd be my preference to have a board packet, the full thing.
So we will mail
week or so
them,
in
it's
advance.
likely that you would get them the Monday before the board meeting, is that sufficient?
Even that's better than, I mean, if you can email them and mail them, if there's any way to get them so that they arrive on Friday, or if we could have them mailed to our home address, we'll get them Saturday probably.
One thing
Okay,
I'm having a
I'm
problem
happy.
with is I don't work, and I have internet at home, what everybody else has, it's about $100 a month, I guess. But our service provider, we may go 3-4 days at a time and not be able to get online.
so, do
With
you want to
charter.
pass
Yeah,
the
all the time,
paper
yeah.
and get people's home
So-
addresses?
And we never know when it's gonna be.
If you're interested in having it mailed to your home address,
So, you know, I may go for a month and not have any problems with internet. Then there may be 4 days I can't get on at all or something.
Mhm.
So it looks like I don't respond to you sometimes timely when it's, you know, we have a CFAC office in Lenore that I could use, but, you know, we're talking about me getting in a car and driving an hour.
Well, I will try to remember to talk to Jill, but if you happen to be able to mention it to her,
I think that's the biggest thing for me though, is most of the people that come to these meetings are professional people. And they have an office and office staff, and they have this and they have that. And I don't have all that at home.
I will make me a note on there with your address also
Okay.
to send you your board packet. And I'm happy to just include it all together for you.
a lot of times we don't have it printed ahead of
I
time.
can
You can just
print
print
that,
one.
there will be, Pat, and you realize there
You
will,
won't get a
there will
complete
likely
one.
be additions to
Okay.
it, but you'll have the basics.
You'll get a complete performance and quality packet, you may not get a complete board packet.
that's great. I don't know if that helps you or not, it just helps me be able to look at it beforehand.
Yeah, that's
Do you
great.
need approval of the schedule, or are you just giving it to us? Do I hear a motion to approve the schedule of reports?
So moved.
I'll second it. And then, we have a motion and a second to approve the schedule of reports. All in favor say aye. Aye. Opposed, nay. Motion carried.
Does that mean you don't want them in paper, or you want them at your
Yeah, I
business
just don't,
address?
I'm used to doing electronic, and
Cool.
I just be something.
Okay, then, next item, I just wanted to let the committee know, we had an unscheduled URAC visit. URAC is the agency by which we are accredited, and accreditation is required by our contract with DMA. We had 3 corrective actions that we have to implement. We have policies and procedures that are out of date, which means they have not been reviewed in the past year. I think that with the merger with Western Highlands, some of the routine things kind of got lost, but I just went to a training this morning for an item called Policy Tech, and our policy and procedure creation and updates will be automated, so there will be no policy and procedure that gets left behind because it will be automated scheduled. We had a credentialing corrective action that we needed to add, which was checking liability insurance for hospitals prior to credentialing the hospital instead of at the time of contracting. That's been corrected. And then for expedited appeal requests, and this has to do with requests for Medicaid recipients whose services have been reduced, denied, or terminated, we need to actually give them a phone call within 72 hours of the decision in addition to notifying them in writing. And we were missing some of the phone calls, documentation of some of the phone calls.
How serious is it that we have to do corrective action? Is it,
Not, well, depends who you talk to. I like not to have corrective action, but it has not jeopardized our accreditation. It has not put us on provisional. It just means they're gonna look closely at these items when they come back in a year and a half for our scheduled visit.
So what you're telling us is, but you have either addressed or actually changed things relative to the corrective actions they brought up.
We have created plans to correct them. We've either
Okay.
corrected them or created a plan for correcting it, yes.
And is this pretty typical for an unscheduled site review to have
Yes.
3 or 4? I mean, I would imagine with the number of policies and procedures. But maybe not, I'm not sure about your act.
I don't know, but in light of the glowing exit interview, I think it probably is pretty typical. One of the items was in your act, they have some mandatory items, and then they have some like best practice recommendations. 2 of our items fell in the mandatory category and 1 fell in the recommended category.
Okay.
I say it's pretty minor. I mean, given what we get, our number of our agencies get, unscheduled reviews regularly. And it's not uncommon to have some things come up. And normally what happens is if they're really big items, they're red flagged that day and there's a requirement of a, immediate response or change or something like that. And those are pretty rare. They have to find some, this looks
Yes.
pretty,
Yeah, it looks pretty typical.
It is, I mean, we had the corrective action plans written prior to her leaving our site, and she took them with her, so there is no, we didn't even have to submit a plan of correction because we had documented our corrective action plans.
That is great.
that's pretty good.
Julie, could you speak just real quickly to the recommendation around in contracts with, it's the 3rd recommendation in contracts with providers.
Okay.
Example, we're just talking about not cherry picking. Is that something that y'all decided to take an action on? I know from the provider community, it's been a concern for a number of reasons.
And thus, she recommended that we add something to the contract, and so we're obviously going to have to go to DMA with that because we use the state mandated contract and we're not allowed to make changes to this contract unless we negotiate it with each individual provider. So, she recommended because of that concern, some language be put in the contract.
Okay. Is that something y'all are looking at or a recommendation, or is that something you're still in the
It's something
process of
that
evaluating?
Christina will take to the Business Practices Standardization Committee that's statewide.
Okay. Well, that's a great.
I know that in the new agreements that the state sent out, there is a problem. They left out human rights committees, and some consumers and some other folks have been talking about that. And that was talked about Friday in Gastonia when at the state and local CFAC gathering for the state.
Well, to be honest, I haven't seen the new template. I've heard that they are combining the DMA and the DMH contract into one contract so that we only have to have one contract with each provider instead of 2, but it hasn't been shared. I haven't seen it.
Oh, they did leave out human rights committees, and they say now they're out of compliance with the laws. So
Yeah, it is in legislation.
That's something that's gonna have to be added back in. So I just kinda wanted to tell y'all so
Okay.
that when you're doing it, you know that that's missing.
We'll let Christina
Good
know
catch.
that too. Any other questions or comments on the ERAC?
Congratulations.
Yeah, that's what I was gonna say. It
Thanks.
sounds.
We had less than a week to prepare for it. So, Mr. Chair, is it okay if we move forward?
You just keep, until you
Okay.
hear us say otherwise.
Okay.
Just keep carrying. The only thing I'm watching is the
Okay.
clock is moving,
Okay.
and let me know when we need to take an action, otherwise we'll just,
Okay.
it's more of a discussion than anything else.
So, just to orient you, Carl, and
Thank you very
Duncan,
much.
to this, performance improvement grid is actually, we have a lot of reports, and so sometimes we don't meet the standard, and we have to have some, we wanna earmark that for our internal conversation for improving performance. So we just put all of it in one place. And that's what this is here. So you'll see the performance improvement grid, and you'll see in green the report that the corrective action relates to. I do want to note that this report has been updated, and I'd like to note that for these items, on the first page, although we will track them to ensure 6 months compliance. We are at or above state standard for the month and year to date. We had been having some difficulty, even though our average speed of answer time for calls into call center is like 7 seconds. The number of calls that we answered in under 30 seconds, because of the high abandoned call rate, was lower than 95%, which is the state standard. And I'd also like to note that Dr. Heck last month pointed out that that is much higher than industry standard. Their expectation of 95% is higher than industry standard. So that was, but we are
Seems like a
getting.
tall order.
Mhm. So it's really good to know that when you make internal changes and implement some corrective actions, that it actually works.
What happened to B and C on the percentage of complaints in March? Is that where it says personnel changes were made because there was a problem?
I
That's a
made
steady number.
personnel changes in March
Would you
because,
attribute that to the change we're seeing in April by those figures?
yes.
Okay, cool, thanks.
Mhm.
I'm sorry, we're gonna go through the entire, I was just
No.
glancing through it.
No, it's
That was
glance
just- they were
through it
just-
and ask
yeah,
questions.
okay.
Those were that was the
This is
only
a
thing
great
I was gonna
report.
point out. And what we'll do is we'll just track this until we're ensured that it's in compliance for a 6-month period of time, and then it will drop off.
And what are the, you say these measures are aggregate of measures in various contracts and standards?
Yes. Mhm.
Yeah, it's really cool. Yeah.
So, for example, the first page, the A, B, and C, relates to this report, the DHHS monthly report. So, you know, and the other items relate to other reports that we will review from time to time.
This is the report that caused me to say, can I get it in written form beforehand? I started looking at this online.
Yeah, there, I don't really have, much to say about the DHHS report because we've met all the standards, so unless you wanna ask about a particular item, just know that we are performed at or above expected, contractual requirements for the month of April. That's what we're reviewing, April's data.
It may not be appropriate, but at some point I'd like to talk about NC Fast and NC Tracks and your experience with it, and how that plays into this, and maybe towards the end of the week, just last couple
I
minutes.
can tell you that for some of the reports that the state publishes, because NC Tracks cannot accept our encounter data, those reports are inaccurate or underreported.
Well, you just nailed the issue there. But let me say, are you able to enter in our data? When you say cannot accept it, are you saying our problem at the county is that we can't get the system to work,
Right.
period? Or is it because we have, or is it that Smokey has systems that won't that track the NC Fast won't accept?
It's
Or is it-
NC Tracks, we can
So
submit
you're on the
we submit
provider
our
side.
data, it's like submitting a claim, and we get a lot of denials because of the way it's set up differently from how we're set up, and
When Duncan submits for reimbursement, his
To
firm
us.
says you reimburse him.
then we send a
When-
shadow claim of that up to the state.
Are you sending it then through NC Tracks, or are you sending it through?
We're
Or I
sending it-
guess I'm a little confused if you say,
He sends it to us, he doesn't have to work with NC Tracks at all unless he does
Yeah.
Health Choice.
Right, we do.
Smokey pays him.
okay,
Smokey has to deal with NC Tracks.
and so you get your reimbursement through NC Tracks,
Yes,
so
we do.
all those pending claims then are turned into receivables.
For the
And
state
the
funds,
reason I get this in is that it's,
for the state funds they are, but for Medicaid funds, we're paid on a per member per month.
okay, that's right.
And we get most of that upfront.
Right, yeah,
It's a
yeah.
prospective payment, but even that is not accurate, and we have to do some reconciling
Okay.
because of
Do you
the,
have to then, so you have to use NC Tracks to go back, and there's actually a reason for all those financial questions in a minute. So you have to go back in to justify the per member per month using NC Tracks, so you still do that, so your shadow claim, okay.
that and
Now-
our state funds, yes.
Now, do they rely upon NC Tracks data to determine a lot of these reports?
Not these, now this report, this DHHS monthly report, we self-report on this.
Okay.
But some of those reports in your binder, the performance contract report and the community systems indicator, community systems, Casper, community
Okay.
systems progress report,
They'll be as accurate.
they get the data from NC Tracks, and you're
So-
correct there.
So, I guess what I'm getting at is that all of this that comes through NC Tracks is gonna be suspect, not because of it being entered, but because the system, although NC Tracks is much better than NC Fast, which is what we do for eligibility as a DSS, NC Fast doesn't work hardly at all. NC Tracks works better, but it still has problems.
So, where,
I guess that's what I'm
where
trying
we're
to get at,
impacted by NC Fast, if it's Medicaid eligibility,
Yeah.
it gets sent up to the state.
Right,
If it doesn't get sent up to the state, we don't get the per member per month payment for that individual because they aren't recorded at the state level.
yeah, and that's a financial, I'm trying to stay within the purview of this committee, but it's, when you hear about that, it's a
It's-
real issue for all of us.
Well, I've heard from consumers, and I don't know if it's NC Fast or NC Tracks, or if NC Fast is behind because of all the attention that's been going
NC
into.
Fast is behind.
Okay, one of the things I've heard is Medicaid will only go back and pick up like the last 3 months,
No, that's not,
And-
that's not.
Well, for timely filing, well, I guess that might be a different.
My question is, how is all this affecting consumers that need medication and that need care, and how much more are they gonna have to pay out of their
It
pocket
goes back
because
to
this
their
is not
date of
processed?
application.
Right.
To their date of application.
If they're not.
Right now, what we can do for our Medicaid folks is, right now, we're having to enter all new applications on NC Fast, which we're getting backlogged and then we're able to do recertification through December 31 on the EIS, the so-called legacy system. And effectively on January 1, we're going to put that all into NC Fast also. NC Fast determines the eligibility of a consumer, and that's where, so there's a problem there, but there's no real problem until they go for service. Because
Right.
NC Fast feeds in NC Tracks, which is what providers use to get payment or to get services
Right.
generally. And if it doesn't show up, if we can't get it in on NC Fast, the eligibility, you can't get, the provider can't get payment, and you walk in and say, I'm eligible, and then it goes, no, you're not. And that's.
And also it can't-
Does this include medication?
Yes, it includes everything.
Everything.
So they can't even get their medication if there's a problem.
That's
Right.
why
But I
it's-
think what you're referring to is that when a consumer goes somewhere for service, that the DMA will only pay the provider.
Right.
Even though their Medicaid is eligible 6 months back, DMA will only pay the providers 90 days prior, anything 90 days prior to the consumer's notification.
I've been hearing a lot of problems from my peers about real problems getting medication, having to spend
Yeah.
household expenses for medication.
If they
And
can
not so
go-
many in this area, but
If they could go to their provider, whether it be a medical provider or a behavioral health provider, there are prescription assistance programs that through pharmaceutical companies.
but sometimes they take 2 or 3 weeks or a month,
Sometimes
and a
they
half
do,
to.
but it's worth a try.
And the other one
And
that
they
you
are.
go to, that
It
you
might
go
be
to,
better
is
than-
if they, presumably they applied through their local DSS, their county DSS, talk to them. And talk to their eligibility folks at the local DSS. That's the entree into the system for a lot of folks and who are on Medicaid. And we are keenly aware of the problems with the state computer system, and they're getting tons of training on how to deal with it. But the reality is, most of those people really care, and they'll know about things like what Julie brought up, maybe other assistance in the community that may be available through churches and elsewhere. Our eligibility people have just gone crazy trying to keep people
On the medication.
or whatever it is that, food or whatever it may be, as we've gone through this nightmare with the state system. And we get blamed for everything, but in fact, it's our DSS people on the ground who have been providing the services through this stuff. So, and the providers have been, like our hospital and our providers have just been super. And our hospital was carrying millions in receivables because they were still providing the service, but they couldn't get paid because NC Fast wasn't accepting the information from NC Trax wasn't accepting it from NC Fast. So we've had a lot of providers be out with receivables that have gone skyrocketing, and they've had cash flow. I don't know about you guys, but we've heard stories about cash flow problems that have been nightmarish.
But certainly affects the quality and performance measures. The other thing that you might be hearing, Pat, is that, and I don't think it's typical of most providers, but some, if somebody's shown as being eligible for those benefits, then they're getting bills for services that really should be covered. And it seems like that might be what you're hearing.
And some of my peers, especially my age, are dual eligible, which is Medicare and Medicaid. And it seems like they're having more problems.
If they're Medicaid eligible and they're going through these computer systems, they're having troubles right now. And that's why I say the best thing to do is to talk to your local DSS. You have to go, I mean, folks who are involved are getting recertified every 6 months, but don't wait, talk to them. Go in and see them and talk with them, because they're keenly aware of this issue at the DSSs. And that's pretty much the entree point
Any
for
idea
all
when
these
they're gonna
people.
fix it?
If it gets real cold next winter, something will freeze over maybe.
Okay.
That'll get me in trouble, Jerry. All right,
No, you got yourself in trouble.
okay.
But I appreciate you bringing that up, Pat. It's a true issue for our consumers and families who aren't even consumers that are needing other services as well. It's a community issue.
And this is one where Smokey's caught right in the middle, because they really are, and we've got people. That's why you hear the DSS people screaming so loudly, because they've been working with clients and citizens for months and months and months on this. And Smokey can take it so far, and it's great that they're paying, but that means Smokey's out the money too. But it also messes up all these reports too. So.
One other thing, Pat, if you run into consumers or families that are getting bills for services because their eligibility is getting lost in the system, typically Smokey has comprehensive providers in each region where they can go receive services regardless of their ability to pay. It might not be medication. Sometimes there is help around that, but certainly for basic benefit services like group therapy or even some individual and family therapy, primarily assessments and group therapy, those are available to consumers in every county that I'm aware of, regardless of their ability to pay.
Okay, that's great.
We just hijacked live staff discussion, but I hope we're on line with what you were doing.
That's okay. The next item are 2 pieces of paper. You got this large report, and like I said, I don't have anything to say on that. And then what Pat's looking at, that's just a graphical representation of the data. Some people like to look at data tables, some people like to look at visuals, so I bring it both ways.
You're so nice. Some of us do better with pictures versus words. So.
What Dr. Heck asked about, he referred to an article last month, and we mailed that article. Tommy emailed it out to you after retrieving it from Mayheck. And so there are 2 single pieces of paper about follow-ups within 7 days and within 30 days. Well, actually 3, 7, and 30, because the article, this is a quality measure that Dr. Heck mentioned, that it showed that suicide rates decrease if you can follow up after a crisis service or an inpatient service within 30 days.
Can you walk through this?
I sure can.
Take a moment.
So what we have
Okay.
is in this, it's called follow-up after hospitalization. However, this is about follow-up after several services. So in the left column, when I looked at this, totally disregard that combined row. I figured out what it was, but it's not very meaningful, so we'll just look at, the left, we have detox and facility-based crisis. Why we have it listed, this is okay, I do need to say, this is a new report in draft, and it has some glitches, so you will see, it has detox and facility-based crisis listed, and then it also has facility-based crisis listed. But let's suffice it to say that facility-based crisis is a community-based crisis service, short-term, that we require follow-up within 7 days. And then you have your inpatient stay there, and your psychiatric residential treatment facility is like a long-term inpatient for children under 21. So you have the numbers here, and then you have the number that received a visit within 3 days, within 7 days, and then with our percentage that received a visit within 3 days, 7 days, 30 days. Actually has the raw number and the percentage. Now this is a good place for you guys to provide feedback into how this could be presented to be easier for you to read and more meaningful once we actually get that.
So is the total number 153, there wasn't anything more than 30 days, or were there anybody where we didn't do it? There's no aggregate figure of the, or is that the total, next column, total number of discharges?
Well, if we look over here in the last column, we see
I see what you did.
86, if we look at the inpatient row in the last column, 86.4% of individuals receive a visit within 30 days. Now, let me say that the data we have is about behavioral health providers. Some of that 14.6% of individuals might have been seen by their physician, and that actually does, in Dr. Heck's performance measure, that is considered a face-to-face that does impact the suicide attempt, or a next suicide attempt. So what we have here, Carl, is because NC Tracks isn't available, we have only our data. We don't have medical providers' data, Medicaid data, and we have only Medicaid data, paid Medicaid, because the indigent, if we don't have shadow claims, or if they're seen and we don't pay for it, then we don't know.
But the bottom line is, over 75% of those patients served in an inpatient facility have a follow-up visit within 3 days. That'd be interesting to hear what his
Yes.
comment would be on that. I mean, is that, I mean, I wouldn't know if
Yes.
that's good or bad, it sure seems great, but
That's
really
that,
good.
but I don't know what that, okay, yeah.
It's really good, and then the 80% within 7 days, 80.8% is within 7 days is really good. We would just like to get it 100% within 30 days.
And you may be.
You'll
You
never,
know,
you'll
you
never,
may- or you may be
you'll never
missing
get it.
No, we'll
you
never
could be-
get 100%,
Right, right.
no.
You have
But I mean,
people
but-
that move, and it's still a choice about whether they want services,
Exactly,
follow-up,
yeah.
and some of them say, I don't want anything.
Yeah,
That's what got me in inpatient, when someone asked for help and I went up in the hospital, I'm never doing it again.
you're
Now, we
right.
don't like to see that, because their chances of relapse are a lot higher, but still.
So this one, the first page that you have, the vertical page, is for individuals who have a diagnosis of mental illness. And the horizontal page is individuals who are hospitalized with a primary diagnosis of substance use. I don't know why it has dollars, but we will fix this report to make it more meaningful. But I did want the committee to know, because the question was asked. So we are working on this report. Do you have any other questions about this report? The IDD dashboard is something that we came up with because about 2/3 of our money is, the IDD dashboard is this, about 2/3, not quite 2/3 of our money our Medicaid money is spent on individuals who have diagnoses of IDD. Because of the high cost of care, the intermediate care facilities, as well as the innovations waiver. However, you can see at the bottom, the analysis is that it is less to maintain somebody in the community, $61,000 a year versus $92,000 a year for a community-based ICF and $175 for a developmental center. So the more we can move people from one of the state developmental centers into community-based ICFs, intermediate care facilities, the better for cost savings, and then ultimately the better for the individual if they can be supported in the community. And it is a cost savings, but more importantly, it's better for the individual because they get integrated into the community and aren't isolated.
One of the issues that, sure everybody here, is just, I met with Brian and some of the staff the other day about our maintenance of effort funds from the county. We're talking about issues, and the number one issue in our county that we get comments on, and they're just crushing comments, and you guys probably hear them too, more than I ever hear, is from aging parents who are saying, what's going to happen to my developmentally disabled child, whether it be, and I'm sorry, I don't know the correct terms, but whether it's IDD or physically developmentally disabled, and you know, you hear this, and that's our number one, and there's not much we do with MOE money, but it was, you know, what do we do? And it's good to hear that there are a lot of programs, and that's the only concern I have about the community-based, is that relies upon the family so much, is how do we, the reason I bring that up is how do we circle back around to help the aging families?
If you look in table 8, living arrangement, there's alternative family living, which
It's very good in some places.
is very good in some
Yeah,
places.
it's just something our board gets, it is something rare,
Yeah.
because normally I don't get a lot of calls about it. These are just crushing calls that you receive from people, and it's just, it's funny, because this is my draft memo about the meeting, it's actually the first bullet, service to aging parents of developmentally disabled youth, many times adults, so, yeah.
So, any other questions or comments about the IDD dashboard?
Just forgive me for being late.
That's right. I'm Carl Klassen, I serve as county manager of Rutherford County, Jeff.
Yeah,
and
nice to meet you.
I think you know everybody
I
else,
do.
I just haven't had a chance.
I was
to-
here last time, but I,
Good, and I missed it, so, good.
yeah.
There's a lot of talk, I guess there's a lot of controversy going on about relatives as providers and how many hours they can get. What can you say about that?
The relatives as provider, you know, I'm not well enough informed, I don't wanna get myself in trouble. If we have questions, any venue, anywhere, we have a committee, relative as and we're starting to call individuals who provide services to their loved ones, relatives as direct support employees, because that is a more accurate term. They aren't actually a provider agency, and there is a national organization, direct support providers, and it's moving toward that language. So, what I do know is that you can't go above the 80 hours, and that it's difficult to get approved over 40 hours. The reason being is because when a relative provides services to their loved one, sometimes they don't get as integrated into the community as is the intent of the waiver. And so that's why it takes some more scrutiny and a higher level of approval to get approved for services beyond 40 hours.
What about for those families where the call I received probably a year ago, and the gentleman couldn't have been more just wonderful. He says, you know, I'm 82, my wife is 80, my wife's had hip surgery recently, I've got some other issues. We're getting to the point where we can't take care of, I think it was their son, and you know, they're relying upon their other children, siblings, things like that, but at some point, that family, he was calling to say, we're getting close to the age, what do we do? And at that time, I got in touch with the folks at Western, I don't know the outcome, but do we have methods for, we can keep them in a community, it may not be the same community, but a different community where another family is able to, you know, assist that child, or whether it be a sibling or a grandchild or a niece or a nephew?
Or alternative family living arrangements, which are homes that, of families that are willing to be a paid provider for an individual and care for that individual in their home.
So all of those are, so we
Options.
have good options for people in that, because we have, I'm just surprised at how many people are facing that nowadays.
We have options, I don't know whether they're good options, but,
Well, yeah,
but the
that's-
other piece of the puzzle is, the network gaps analysis and needs assessment, and then after that is a network development plan. And if we find out about where a service is needed, or then, that network, we are supposed to address it in our network development plan.
Okay.
And we are going to, in the board meeting tonight, hear a presentation on the gaps analysis.
Thank you. Keep going.
So, let's see, really, the operations at a glance, I really don't have any, that's just there for review, and if you have questions, I don't have anything to say about that. Since we're limited in time, is it okay with you, Carl, if I skip to the Access to Care quarterly report?
I just wanted, Jeff, one of the things we passed earlier, some of us have real trouble reading this online.
I can't everything out.
And, well, I'm gonna say, the other thing we've asked, a couple of us have asked to do is just print it mail to our homes, that way we get it like Saturday before a meeting. Or print it all out, whichever works out best for you. We did that earlier before you got here, that's all.
Yeah.
So, yeah.
I have to print it out.
I can't read it online, I've tried this time, and, you know,
Carl, can I ask a question?
we're not supposed to take public comments, so be careful what you say, Jerry.
Not public comment, a question. On the innovation waiver, on the waiting list, the numbers that you're looking at, you've got 800 and some on the waiting list. And what you was asking in form of a question to her about what is being provided, or what can be provided, you've got people that's on this waiting list that they're getting hardly anything. And you've got a total number of 1,600 and something that is on the innovation waiver. So my concern is your concern, and I'm getting down to a little more rubber than you was there. And that is the, what is being provided for those that are on the waiting list? And how can we improve that?
That's a very good question.
But let me be careful here, because
Okay.
we don't take public comments at committee meetings and things like that. Jerry, here's what I'm asking you to do. I know you've got my email address.
Sure.
Would you take 30 seconds at home and email me that question, and then let me enter that in as a part of this? And
don't-
that way, I gotta be real careful about how we
Sure.
do the committee meetings. But could you shoot me a note to that effect?
Sure,
And
I'm
I'll get
happy.
it in the system, and we'll take a look at it, okay?
I'm happy to do that.
Thanks, Jerry, appreciate that.
Yeah.
The reason I wanted to go to the Access, I don't have, the Access to Care report is because last month, Pat had asked, we had looked at our Access to Care report, and I don't have it in my packet, so I'm gonna have to. It's the last, it should be the very last thing in your packet.
All right.
Does that look like this, is that what you're looking at?
Yes.
Okay.
Pat had asked last time about the county, data by county, and so, Steve Leger, our quality management business specialist, pulled the data by county. And when, it's not by county necessarily of residents or of recipients Medicaid, but it is where the call is coming from. That's how we can, get the data. So, this is the number and percentage of calls made into the system from the different counties. And when you look
are
at-
these, what, exactly what are these calls? Are these calls from potential recipients?
Yes.
Or- Okay.
Calls into our call center. Some of them may, we can't, we don't know what they were about, whether they were requesting services or information. But I do want to point out that there are calls made to our call center from counties outside our catchment area, but it might be one of our beneficiaries who's traveling or.
And so my question is, how is this helpful?
I am,
I'm not asking that in a cynical way, but in a.
it may
To me,
be
it's very
helpful, it may
because
be
it gives me
helpful
a-
in terms of knowing where the needs are.
I still a proxy for the need of the,
Yeah, within the region, yeah.
I understand, okay. Because we otherwise wouldn't have that information?
We would have where people access services, but we don't know, but this is actually where the call, initial call is made,
Okay.
the initial
And these aren't
contact.
necessarily unduplicated calls, but these are.
Unduplicated consumers, they are unduplicated calls, but they aren't necessarily unduplicated people.
Okay.
So the person calls 4 times, that's
Yeah.
4 calls for one person.
Yeah.
Yes.
Okay.
Yeah. Okay.
I think
And
that-
it
I think
does
that-
tell us, you know, I think, now that you mention it, if I were looking at this and running the call center, I'd say, okay, then I need to know the most about Buncombe County and what's available in Buncombe County. I need all my employees to know about Buncombe County. And I need to know the next most about Caldwell and Rutherford, because the individuals who answer the phone, are those who say, oh, well, we have 5 providers in your area. So, I mean, if I were running the call center, it might trigger that in my head.
To what extent can we drill down into that data within the call center to find out types of calls and stuff? You know, we really are urging people to call the 800 number.
Yes,
And so that is a good indicator.
we can get you types of calls.
Yeah,
This
or
just
some-
isn't it, and it's
I
not
know,
the
I know.
access to care report,
Yeah,
but yes, we can do
it's-
that.
It's a different one because it does give a level of
They,
desire by the citizens as to what they're needing and what they're looking for, which would indicate, you know, are we meeting those needs? You know, it doesn't follow through, like the aftercare report you'd ask for, we ought to go back to while you're here. You know, the 3 days or 7 day follow-up, and we go back to that, but at least it gives an indicator, and I like it by county if possible.
yes, we can
Just,
do
you
that.
know,
It just
obviously
depends
that's
on the
what
kind of
I'm
report, because when a caller calls in, then the customer service representative answers the call, and they enter the type of call. We can also tell if it was a call for an appointment, whether it was routine, or whether it had to get passed on to a clinician,
Mhm.
because it seemed to have a little more severity associated with it. We can get you that data. If you let me know what you want, I can, like with those follow-up reports, we can start to get it and bring it here and then
Can we-
develop it to
let me
further
ask-
answer the question.
Let me ask you a different question. Could you check, or maybe you take a look, or talk to rather than us telling you what we'd like to see, because sometimes we don't
I'll
know what's
pull the
really
report
effective.
and then
You
can-
take a look at it, or work with the call center director and say,
Yeah.
what could be easily provided that really is meaningful versus just data? And that's, you know, that's, you guys are professionals. I just thought that was,
And what tells the story? I mean, the real issues that you want in terms of, you know, really look at access to the care needed.
Are they, in Rutherford County, if 2/3 of the calls are for mental health or substance abuse, and 1/3, and yet every place else is different, that's just an indicator in, you know, what people are needing. Or it might be the opposite, or there might be a spike or something, I don't know.
So,
I'll tell you what I'm like, when you're done with the reports, and I'm looking at what we have, it's about 355. Can we go back to the reports on the follow-up care, because Jeff wasn't here, that was,
Once again, sorry you have to play over this again, but
No, no problem.
It was great to hear, because we know the reason you're asking, frankly, I'm sitting here going, I'd like to hear your take on it, because we talked about it, but we don't have your experience in looking at it.
I took a little bit of a risk bringing this here because it was just when I asked the question, they said, oh, this is what we can pull. So Jeff, it's these two documents, it's a single horizontal document and vertical document.
okay.
Um,
Is that good? Yes.
Now, I do have to say, it isn't a very clear report, and it has a
But you gotta
few
start somewhere,
glitches.
but you gotta start somewhere.
For example, this combined line isn't very meaningful because it doesn't tally correctly. The second two lines, one says detox and facility-based crisis, and the next one says facility-based crisis only. We don't really have a definition for what differentiates those. But the bottom line is, for these crisis services, especially for inpatient, where it looks like we're a little better at inpatient, and what I explained to the rest of the group is that this is our data, this is our smoky data, so we don't necessarily have follow-up appointments that might be made with a primary care physician.
Okay, I'm still trying to work, I'm looking at the right one, so I'm looking at, what's the end?
If you look at,
Maybe walk through the inpatient line like you did for us,
Okay.
that time, Julie, that helped me to understand it a lot
so,
better.
I don't,
I'm not sure you're looking at the same
I have the
document.
total
Okay.
number of
Julie,
discharges.
make sure you're
Am I
both,
looking
you
at the same-
definitely the same document.
Yes,
Okay.
so if I look into the second to the last line, inpatient,
Yeah, I have
my
it.
total number, if I go to the middle, 177,
Uh-huh.
that's my total number of discharges.
Okay, so that's your end. And then your,
So, 135 of those individuals received a follow-up appointment
Mhm.
within
I got
3
you.
days. And then, of course, the 143, it would be 8 additional, would be my guess, were seen within 7 days, and then 10 between 8 and 30 days.
So 24 of the 177 did not have a follow-up point
Correct,
within 30 days.
correct.
And the percentages are those last three
That's
columns.
the way I interpret it.
Yeah,
And apparently there's an issue on but of those 24, the question is, if they went to a private provider or doctor, went to a doctor, we might not know about that they went to see somebody. So we don't know if how distorted that is because we don't have NC Tracks data because
yeah.
NC Fast, NC Tracks, thank you very much,
Yeah.
blocked my life. Yeah.
Right, so so to me, as I look at it, this is great, actually, this is really good information, and of course, the reason for asking it to begin with is that the risk for readmission or another crisis situation is enhanced immediately post-discharge. So, and I would say these crisis numbers too are important. So
Yes.
you add on top of them, another 5 patients, you got 29 patients who would be really interesting to look at what actually happens to them.
Mhm.
So if you could take those same 29 patients and drill that down to say where either with phone calls or some
Mhm.
more intensive look. And of course, we're going to be doing this as soon as we get into a whole different capitation arrangement. This really matters because if these patients, if these are the ones, if we find that none of these patients actually show back up in the emergency room and they all got private care or they all got some other care, or maybe they were well enough that they didn't really need it or want it, they got it through their primary care physician or their pastor or somebody else, then it's no big deal. But if of these 29, if 15 of them ended up back in the ER or committed suicide or something more drastic, then you know that you have a really important targeted population. The data would suggest, I mean, the national studies that would suggest that those 29 people are at really big risk.
Julie, is there a way that you can check with the staff to see if we're able to, here we took October of 2013. one
This
month.
was just a sample
Oh, that's okay,
report.
that's okay, but is there a way to get, to talk to the staff to see if we can find out what happened, in this case, to those 29 people in October of 2013? And then they said, we can't do it for October, we can do it for January. I don't think
Right.
that, I don't think the issue is the month as much as, can we pick some month where we get this report, find out, and then take a look at what happened to those other people? Do we have
Yes,
data somewhere within our system that we can do that?
yes. What we would do is we could crosswalk, we have the number of discharges, so we have the names of the individuals who were discharged. We have the number of people seen, so we have the names, and we can come up with the names of the people who weren't seen, yes.
Yeah,
Could we then make
that's great, Dave. That's awesome, you could do that, that's awesome.
I didn't know this report was already in the system, and we actually have a really good, we have good data people. And I don't know where he heard me ask about it, but he just did this after hearing me.
Yeah, well, I mean, this affects real people, these are, the ideal system is one in which you devote the most of your resources to the people who need it the most, and it's always hard to know, like, who are those people? So,
Could we
that's
make
true.
that request either for the next month or the following month,
if-
maybe depending on your timing? I know it's important, but I don't wanna.
What we need to do is first validate this data,
Yeah.
and then.
That's what I'm saying, it may take a couple months. No, I'm not saying you gotta have it by next month, but, if
Mm-hmm.
you could pick a month and drill down on that, and then maybe we can use that as a benchmark to see how we're doing in the future too.
Yeah, and it might also guide, like, what resources are missing, like, I mean, if you could guess that these people may, if they are like ending up back in the ED or in the hospital, you could guess that maybe they didn't have transportation, or they didn't have a telephone, or didn't have, there are all kinds of things, which may be simple answers, there may be really complex answers also, but you'd like to think if there were some simple interventions, you could help these people substantially, so.
I think that another data element, you were interested in the number of ED admits that were readmissions within 30 days, and that number is fairly high for us. But I think another,
Jeff, that's in these green charts.
Okay.
It's kind of moving way down the
the
first one.
legal size paper. I think,
Number of admit, you've got it highlighted.
Yeah.
I wonder why I did that.
Wow, those are high.
Mm-hmm.
And see, I see. So half of those patients, am I correct? So half of the patients, or the consumers that are into the ED are brand new.
Providers,
Half come back within 30 days.
55% of the people admitted have a provider of record,
Mhm.
and 45% of them do not. So we could consider them new or having been inactive for 180 days.
Right. And of course, and that's, so I would turn to my own work, this is really helpful in primary care, is that we've got to get them identified earlier up the chain so that those people who really are headed towards a crisis can be identified earlier and entered into treatment earlier, because you would like to think that there could be some prevention there, but that's helpful. I got a sneak preview of that information, by the way. I heard it from the hospital, so, but that's good. I mean, it's good information, it's
Good
kind of
information.
disappointing.
It is.
I was gonna say, it's
Yeah.
good information, but not the information you wanna hear.
Yeah, yeah. But, I don't know that that's really out of the ordinary. I mean,
I don't know either.
we do a pretty lousy job overall in terms of community identification in the broader sense for those people who are at risk. But increasingly with better analytics in primary care offices, we could do better. We couldn't be perfect, but we could probably identify the more integrated care and primary care. I mean, those are some really important milestones, and this is good data to show that it would make sense to try.
I would think the hospital would be fascinated with that. That's an extremely expensive line item for them.
Oh, yeah.
I mean, that is just horrendously expensive.
Yeah.
And I would think they would be interested in that as providers. And they would be the first ones to jump on the bandwagon and say, wait a minute.
So, I mean, I know these are conversations that Brian's having,
Yeah.
and we're having,
Yes.
Brian, we've been meeting
Yes.
actually with CCNC and MAHEC and the hospital, and
I would think, yeah, Mission and the other members of the WICHE, I guess, we know WICHE, whatever it's called, WICHE, just because our hospital administrator chaired the mental health committee, and like, she goes, why am I doing this? I said, well,
Yeah.
because you are. So, but, this is apparently a huge issue in these
Yeah.
emergency departments.
yeah, and of course, the real answer is prevention. I mean, it's getting treatment earlier up the chain. And that really starts, and that's public health, it's schools, it's, in the community, and then it's also in primary care, but it's a very big task, but a worthy task.
Yeah.
Right. That's good.
So, then next month, we will definitely review, that completes all the reports. We'll definitely review the QM annual report so that you can see what quality measures we're working on within our operations and smoking. And that actually will require, when we meet next month, that when review it, it will require the approval of the board. When you present your report to the board, you'll have to request that they approve it. I'll try to remember that. Then.
One thing that I would suggest we eventually work towards, which would be really terrific, and having worked with data to manage our practices, one of the things that I have ultimately concluded is that the best kind of data dashboard is one that really has the only information that the most important information. So as people who love data, I mean, I love looking at all this stuff. This is really interesting. But for the average person, there's probably like 10 metrics that ought to be right in the front of our face every time to measure, are we being successful or not.
And I think, Jeff, over time, as this committee meets and the staff works with us, I think we'll develop that. We'll be zeroing in on some, as we keep asking questions, going back to the same data, having done enough financial stuff over the years.
Right.
I got to the point where we could look at an entire organization
Yeah.
on one sheet of paper and say, here are the key parameters.
Right.
And it wasn't everything. It said, like Julie said, sometimes you gotta go through the whole thing, the QM report, the annual report. But you're right. On a monthly basis, we're gonna zero in on those, I bet. And we'll just have to give it to the staff and ask them, can you provide it?
Well, just for my short, or do you have one already?
Well, it's not what you're talking about, but this, I think the best examples of what you're talking about are this IDD snapshot and this operations at a glance. This might not be the data you want, but it's an example of concise, this is an example of smoky operations on 2 pages.
Yeah.
It's in the middle, sort of, and it's,
I also like this performance improvement grid, because it says, somebody else has looked at us and said, here's what we need to do to fix it, and here's what we're fixing it. And the reason I like it is only because we're getting inspected constantly, making sure that we're responding to that too. It's not a service level, but it's more of an organizational issue, which.
I mean, if I just was to blurt out what would make them, what would really be awesome if we had a chart and we looked at our monthly, what's our percent of readmits to the hospital? What's our percent of people who within 30 days didn't get? And it was all in one thing. We were looking at every month and you know, and hard stuff that's really difficult to achieve, but stuff that we know is meaningful in the community. The number of people who are on the waiting list, because obviously the better we manage everything else, they get off the waiting list because there's more resources available. That would be a way of us.
I do need to say that they can get off the waiting list when the state gives us more slots. They can get services while they're on the waiting list, but they cannot get off the waiting list into an innovation slot because we have a finite number of slots.
Yeah.
So I didn't wanna,
Well, but I'm just saying, but that part of
that
the
has
data
nothing
may
to do with
be,
how well we manage our money because we
No.
get the number of
To help
slots
you
from the
manage the
state.
state.
Yeah.
I know you're looking at organizationally, but part of what we all do outside of this room, or as board members, is we're focused on getting that service to people. And
Right.
if we show that, you know, percentage
Yeah.
of, we have this many people waiting, and we have this many slots available that are state funded, we know maybe what we need to do is talk to the board and saying, here's a problem we need to go talk to the state about. I mean, if there's only gonna be 4 of these organizations in the near future, somebody's got to tell the state, here's our problem, we need help. And be upfront with them as in our own private capacity, our own non-board capacity.
And I do think that they're working to create a waiver, an additional waiver with a maximum dollar amount of $20,000, and they're hoping that that will assist some of the people on the waiting list. But one way we can, with the savings when we manage our money, is reinvest in what they call the B3 services.
Yeah, that's awesome. I mean, and that's where we can really invest in prevention and care and public health. And I think, again, it's, I mean, you've got some really great data here, but it would be nice for the whole board to hear from us. What are the things that we're gonna count as success? So what can we measure and show from month to month that we've actually moved the needle some way?
Well, if we want to pick some measures, that would be great for this committee to track them. May require some development of a report that we don't already have, but a lot of this data we have.
Well, you've made a fatal flaw. You've shown how good you are at getting data. So you've really piqued my interest in this.
So we really have two benchmarks. One is the benchmark of success and the benchmark of need.
A benchmark
Benchmark of need.
of need, yeah.
And,
Yeah.
you know, that, it's not that we're failing, it's just that there are certain needs that we're not gonna be able to meet for some other reason.
Right,
And it may be one report. Oh, I didn't mention
right.
that. And I should
Well,
report to the board.
definitely need to be more innovation slots. That's at state level.
Okay, well, I assume these reports at the board meeting are like 2 minutes long? If I mean, they want to keep them, if I know
Yes.
Rick and Kevin, they want them fast. Okay, I think I got my notes.
Since there's nothing this month that required board approval, then
It'll be really quick. Good deal. Okay.
The board meeting tonight, you found out?
Yeah, I just didn't know what I was supposed to
just
report on.
reporting out.
That we met and that we approved the items that need to be approved. Did the URAC unscheduled site review. We reviewed the summary of the URAC unscheduled site review, noted the corrected actions, looked at some of the reports that were shown in the packet, because they have all this too, right?
Yes, they do.
And, look forward to developing some benchmarks of success and benchmarks of need in addition to doing our regular work. Boom, out of the meeting. Sound like a good report?
That sounds like a great idea.
There we go, great report, all right.
Meetings that are supposed to be from 4:30 to 6, but end up at 9 o'clock.
Oh, dear.
Thanks for a very grumpy wife. Not really my wife, never grumpy.
You're gonna get a meeting.
Yeah. I was watching the
Yeah, me too.
That's what I say, let me know if you change. I mean, apparently we're looking for a 4th board member to serve.
I think I'm pretty sure that, no, a fifth member of
member,
the
yeah.
committee. Because
Would you confirm that, and I'll talk to Rick? and
there is,
get one?
because it says such and such member unfilled on my list of people who are on the committee. It's, oh, here, it's in the front of your book,
In front of my binder,
yes, in the,
overview?
it's, okay, at the bottom of that page, I think, does it say unfilled, something unfilled?
No.
Oh, I thought that's where it was, that's the list of the board members, and there are so many slots, and one is unfilled.
Isn't that the insurance executive?
Oh, you mean board members,
No,
not this
this
committee?
committee, this
I
committee,
hear,
I keep it in my brain.
I've got 4 people.
and it doesn't say at the, underneath it, something unfilled.
No, it says your name, you're filled. That's your name.
Yeah. Well, somewhere I read that there is a spot unfilled, so.
If you do, let me know, and we can talk to Rick
I
about
can
getting
ask
that 5th
Tracy
member. or
because
something.
she'll
Yeah.
remember.
All right, cool. Anything else anybody else wants to bring up or talk about for this committee?
Just want to note that we sent out what the document that Pat referenced. It is a disability rights,
It's a new Medicaid buy-in document where folks can buy Medicaid if they want to go back to work or something like that. And for some reason, not a lot of people know about it.
because they feel state field.
Well, it says under Medicaid, states may offer buy-in.
Oh, they're offering it now.
So North Carolina did North Carolina, okay, it says right here. In 2005, the General Assembly adopted Medicaid buy-in. Okay, cool.
But they hadn't been offering it even though they adopted it. So now they're having to offer it, but not many people know about it.
Applications for the buy-in are the same as general Medicaid applications. That'll get me started on NC Fast all over again.
By anybody?
Because it says DSS
All right,
officers
and are
may
we-
not be familiar with the program.
Yeah, and I'll find out from Laura.
And thanks for getting the water.
Hey, okay, absent anything, hearing no objection, we are adjourned.
Thank you.
Cool, thank you.